about this intersection between opiate use disorder and PTSD. Next slide. I have no disclosures. Outline for the remainder of the talk. Next slide. Well, bottom line up front, co-occurring mental health disorders and substance use disorders are very common. We have a lot of trauma-associated mental health disorders in our population of substance use patients. It is very important that we screen for trauma-associated symptoms in our clients. And finally, effective treatments exist for both, with integrated treatment being the preferred option. Next slide. Next slide. These are a number of studies, all indicating that trauma is incredibly common. Between 70 to 90% of the adult population has been exposed to a traumatic event. Good news is most of those recover, although not all. Next slide. Looking at studies with PTSD and substance use disorder are somewhat difficult to correlate between DSM-3, 4, and 5 criteria, although in spite of that, not quite the same category A trauma exposure or the clusters, the rates of PTSD with those throughout that time frame, 1980 to DSM-3 to the present since 2013 with DSM-5, about 6 to 7% of the population experiences PTSD, with women's rates being roughly twice that of men. Next slide. Just run through the DSM-5 criteria. Criteria A is exposure. Next slide. B is the intrusive symptom cluster. Next slide. C is avoidance of stimuli cluster. Next slide. D, the negative alterations in cognition and mood. Next slide. And E, alterations in arousal and reactivity. Next slide. In addition to that, PTSD is diagnosed with duration greater than 1 month. It must be associated with some significant impairment, and of particular note, the disturbance is not attributable to the physiological effects of a substance or a medical condition, other medical condition. Next slide. It can be with or without dissociative symptoms. Of particular interest with this particular symptom complex, most people who experience a traumatic event will have a brief episode of acute stress disorder. Those symptoms generally resolve within a day to something less than a month. Those individuals who near the time of trauma or immediately surrounding that time of trauma experience dissociative symptoms, those are the group of acute stress disorder that are most likely to go on to develop PTSD. Next slide. And then finally, PTSD can occur with quite a delayed expression. Next slide. Important caveat, there are a number of mental illnesses that have a symptom complex that overlaps with PTSD, major depressive disorders, anxiety disorders, and psychotic disorders particularly. Next slide. Opiate use disorder. Next slide. Diagnostic criteria for that we're all pretty familiar with. Of note that I have highlighted, 3,800,000 people 12 and older have misused a prescription medication in the previous 12 months, but about 2 million people currently carry a diagnosis of or meet the criteria of opiate use disorder. Next slide. We kind of thought that all overdose deaths were sort of plateauing. Next slide. Obviously, opioids, specifically of substances, had been significantly increasing. Next slide. And that was driven by the synthetic opioids other than methadone, with tapering off of the prescription drugs and heroin. Next slide. I was able to obtain preliminary data, and you can see in the lower map, this is April 2019 to April 20. Unfortunately, only 6 states in the last 12 months have shown a decrease in overdose deaths, with an average increase overall of 13.2%. And in the graph slide above, we are now experiencing a return of a increase in overdose deaths. Next slide. Comorbidity, next slide. This graph indicates the co-occurring substance misuse with any mental illness and with severe mental illness. The reds are without mental illness. The black is with the diagnosis of any mental illness, and the bluish green, depending on whether you're colorblind or not, is those co-occurring substance misuse with serious mental illness. The third graph shows opiate misuse and the significantly increasing occurrence with co-occurring mental health diagnoses. 47.6 million adults in the past year with a mental health disorder. 19% of those also had a substance use disorder, but perhaps most interestingly, only 5% of adults without any mental illness in the past year were diagnosed with a substance use disorder. Next slide. There is clearly a strong association between PTSD and substance use disorder. Next slide. Comorbid or co-occurring PTSD and substance use disorder results in lower rates of remission and faster relapse, poorer treatment response, significant cognitive difficulties, worsening social functioning, and increased mortality. Next slide. I think many people that we see in our substance abuse clinics with depressive symptoms may have something more than depression, and without screening for trauma, we will miss PTSD. Next slide. This relationship between PTSD and substance use disorder is bidirectional. Substance use increases trauma risk, exposure to trauma escalates substance use to manage trauma-related symptoms, and seeking drugs is always at risk for endangerment. Next slide. So mechanism of shared vulnerability. Next slide. There are a number of suspected etiologies for co-occurring PTSD and substance use disorder. Next slide. But there are 3 proposed somewhat causal pathways that have been most reviewed in the literature. Self-medication hypothesis, high-risk hypothesis, and susceptibility hypothesis. And likely, again, it's bidirectional and cyclical. These are not mutually exclusive. Next slide. There are numerous interactions between the multiple monoamine pathways that are overlapping in both trauma and abuse. There are extrinsic vulnerabilities that predispose certain individuals to both PTSD and substance use disorder. And clearly genetics and early life events play a significant role. Next slide. Screening. Next slide. From the very recently updated Substance Abuse and Mental Health Services Administration Treatment Improvement Protocol number 42, the consensus panel recommended all clients presenting for substance use treatment or mental health services be screened at least annually for both. There are a number of screening and assessment measures validated, and we need to choose whatever works in our clinic and screen appropriately. Next slide. This is the screen that is primarily used in across the VA system, the PTSD 5 questions. If there's no exposure to trauma, it's over with the first question, but it is a very quick screen that can be accomplished in just a matter of a minute. Next slide. If patients screen positive on that, a more formal self-report measure can be used, like the PCL-5. Next slide. With the structured interview being the gold standard, the CAPS-5, and these are URLs for obtaining that. Next slide. Tip 63, which is trauma-informed care in behavioral health settings, also recommends universal screening. Next slide. Unfortunately, most clients in substance use treatment settings are not even assessed for PTSD or trauma-related events. Other than ACEs are probably the most common screening that is done. Next slide. Next slide. Evidence-based recommendations for treatment for PTSD under the clinical practice guidelines that have been approved within the VA DoD system since 2017. Individual trauma-focused psychotherapies, including prolonged exposure, cognitive processing therapy, and eye movement desensitization and reprocessing, are the most effective in their trials. The CPG recommends treating PTSD patients with psychotherapy, or trauma-focused psychotherapy over medications. If that's not available, there are 5 medications that on meta-analysis have shown relatively equivalent effectiveness in routine clinical practice: fluoxetine, paroxetine, sertraline, topiramate, and venlafaxine. In the studies, however, no resolution of PTSD symptoms occurred without concurrent treatment with psychotherapy. Next slide. Cochrane review looking at effectiveness of treating co-occurring PTSD and substance use disorder found that the evidence was somewhat difficult to tease out. Quality was low. However, there still seemed to be a preponderance of benefit for trauma-focused interventions, and they found no benefit for medications. Next slide. Clearly, opiate use disorder, MAT, is effective. Methadone, naltrexone, buprenorphine have all shown to decrease, maintain people in treatment and decrease overdose. Next slide. There are FDA-approved medications. Next slide. So, summary of opioid use disorder treatments that most of us in the addiction field are aware of. Next slide. Next slide. So as I gave you the bluff up front, co-occurring mental health disorders and substance use disorders are common among people who've experienced trauma. And as I have shown, most Americans, 70 to 90% in studies, have experienced some trauma. Screening for trauma-associated symptoms in all clients presenting for opiate use disorder, substance use disorder services should be accomplished, and effective treatments exist for both of these conditions with integrated therapy preferred. Next slide. Next slide. Next slide. I recommend tip 42 to you, most recently updated, for further reading on this topic. Next slide. And tip 57 provides additional information based on trauma-informed care. Next slide. Thank you very much.
Thank you, Schuyler. That was very thorough and jam-packed with information. Very much appreciated. We do have a few people, keep moving my camera, who have joined us since we finished with our introductions and went into Schuyler's presentation. So I'm going to quickly ask you guys to unmute and introduce. Simona, you are one of them. If you can unmute, please, and introduce yourself.
Hi, everyone. My name is Simona. I'm one of the Addiction Medicine Fellows.
Thank you, Simona. Good to have you with us. Rick, you can unmute and introduce, please.
Hello, everybody. Sorry I was late. I was actually on a virtual conference. I'm Associate Director of the Medical Library and a professor in the College of Medicine and on the Hub team.
Great. Thank you, Rick. Rick is here to help us out with any literature searches or scholarly articles that we're looking for or needing. So if you guys need to privately message him or send questions about literature, Rick's your man. Thank you, Rick, for being here. Telehealth 2, if you can unmute and introduce. Oh, Debbie. Thank you.
Hi, Debbie Hill in Buffalo Valley.
It's good to have you with us, Debbie. Thank you for joining us again. Marianne, if you can unmute and introduce.
Yes, hi, I'm Marianne Rains. I'm with Centerstone, and I'm a psychiatric nurse practitioner with the early childhood services. And we're trying to spread care to 7 rural counties. And I'm sorry I was late. I was in a maternal mortality task force.
Totally fine. Sounds like a good place to be. Glad you're with us now, and welcome to our group.
Thank you.
You're welcome. Great. I think I got everybody else who joined us. Who has questions for Schuyler on his presentation today?
Will the slides be available to be viewed? Again, I apologize for coming in late.
It's totally fine, Marianne. They are available on our webpage. If Brian, you don't mind just putting a link to our webpage in the chat box. If you go to our webpage, just click that link Brian's going to provide you. Under the resources section on that webpage, you will be able to access PDF version of Schuyler's slides. Because yeah, he definitely hit the high points for us. There's loads more information on them and some really good resources. So yes, that is available. Any other questions or comments?
Schuyler, do you have recommendations about working with, like talking to clients about what to work on first or how to work simultaneously on PTSD and opioid use disorder?
From what I have gathered from the reading that I've done, PTSD symptoms are a frequent source of self-medication by patients, and certainly makes them more prone for triggers for relapse. I think it's really critical that we address the PTSD aggressively while maintaining them in therapy with MAT. I was disappointed to see the relatively limited response for PTSD to medication, and that it's certainly common to prescribe that list of 5 medications to PTSD patients. Cochrane Review wasn't very excited about the evidence for its effectiveness, but clearly exposure therapy, EMRD, cognitive processing therapy are beneficial. It's just the patient population tends not to engage in the time frame that is needed to actually gain an effect from those therapies. And certainly if their opiate use disorder is not being controlled, they will only trigger more during any exposure type therapy. So I think it's not one or the other, it's always both. And of course you can't treat both unless you diagnose both. So you got to screen for it.
David, I think you were wanting to say something, sir.
I think he just answered it. I was going to ask about specific modalities of psychotherapy after he mentioned that pharmacotherapy was not very effective. He just had summed it up as psychotherapy is, and I was going to ask him to say more about that. And he did.
Yes, he did. Excellent. Cameron, yes.
Yeah, I want to add something to this. Yes, there is no definite, medication that can overcome the whole entire symptoms of the PTSD because it's a complex, symptoms. But as you mentioned in your presentation, we do have people that they are suffering from the actual PTSD, but they are showing up as a depressive symptoms. Then antidepressant that you mentioned during that list of the medication would be at least subsiding some of those symptoms of the depression. PTSD certainly has the anxiety symptoms involved. Anxiety medications also listed there that you put the SSRIs and venlafaxine, for example, as a list. So those are the medications that reduce the symptoms. And one of the problem with the PTSD is the patients usually, after the trauma take place, try to avoid really engaging to memory of the trauma as much as they can. And that is one of the natural reaction to maybe it's not the best coping mechanism, but that's why we see some of those delay PTSD happens because they are using some coping mechanism that it's not therapeutic, but it does push the trauma down to the unconscious level of the brain that they would not suffer as much. But then when they get, to the point of the retirement, for example, we see lots of patients that they start having a more symptoms of the PTSD when their coping mechanism was they become workaholic. They were working hard and to push those trauma back. So adding to this, conversation, I think that it's very important to have that rapport with the patient to be able to discuss the treatment that's available and encourage the patient. One of the good thing about the using the treatment of the substance use disorder in the same time is increases the frequency of the interaction that you have with the patient. You will bring the patient sometimes every week, every other week, every month, at least one encounter with the patient. So it's different from the primary care providers that they usually, see the patient for their medical problem every 6 months or every year. So you do have more opportunity to build up that rapport and encourage the patient to get the treatment. And in a severe cases of the substance use, I think that the combination of the substance use treatment in a residential place, in the same time working on a PTSD trauma approach, that would give it even better, encounter with the patient and the provider. So that's the comment that I can make.
Well, of interest, there was a 2015 article that I read that looked at symptom clusters of PTSD. And PTSD looks like it increases odds ratios of substance use disorder 200% in women and 50% in men. And in men, arousal reactivity appears to be the most depressing or distressing symptom complex associated with going on to opiate use disorder. But in women, it's avoidance of traumatic stimuli. That's the symptom cluster that's most often associated with progression to a substance use disorder. So maybe targeting specific symptom clusters of PTSD that are the most distressing for the particular individual that you're treating may improve the outcomes.
Great, thank you, Schuyler. And actually, we've had another individual join us. So Muniza, and please correct me if I'm not saying that correctly. If you can unmute and introduce yourself, that'd be awesome.
My name's Muniza Khan. I'm the program director and chair for the family medicine program at UT Memphis.
Wonderful, it's nice having you. Memphis has shown up today in a beautiful way. Thank you for being here, Muniza. Great. Next, we're going to move on to Tanya. She has our case presentation for today. And actually, Muniza did exactly what I was just going to ask of everybody else who's still showing me the tile that just shows their name. If everyone could go ahead and turn on their cameras for this portion, especially because this is kind of a shared session and being able to see everyone's wonderful faces, so I can tell that the thought is percolating across your brains, and I can go ahead and call you out on it. So if you can go ahead and